Thank you.
The next speaker is Dr. Stephen Walker from UK. He is a clinical lecturer in respiratory medicine at Bristol Medical School. Welcome, Dr. Stephen. He's going to talk about pneumothorax.
Thank you very much. Thank you very much for welcoming me in your lovely country. Thank you for the chairs for introducing me, and thank you particularly for Muda for inviting me across and for welcoming me and showing me around Baghdad. So I'm from the UK, from Bristol. I'm an academic. I'm also a clinician. I've got a specialist interest in pneumothorax, and I'm very pleased to talk to you about pneumothorax today. I was a member of the British guidelines on pneumothorax, which was published as part of the plural guidelines last year. I was also the junior chair of the European guidelines, which were only just published last month in the European Respiratory Society. And it's a very good guideline. I don't know if you can get access to it, but if you can't get access to it, please feel free to email me and I can provide you a copy. So I want to talk to you today, but also more importantly, because I'm here, during breaks or during lunch or any other time, if you feel free to come and talk to me, I think a lot of interaction would be lovely. So please do that. So this is I'm going to talk about pneumothorax care in the NHS, and that is going to be different from care here in Iraq. But there's going to be a lot of similarities. The care in the NHS has changed quite a lot in the last 5 years. Typically, the standard of care that we've had for many years is insertion of a chest drain. So as you can see there, oops, no, I'm having some difficulties with it, insertion of a chest drain. But over the last 5 years, because of recent evidence, we've added to the amount of interventions that we can do. And I'm going to talk about some of the evidence base. And part of the reason we've changed management is in the NHS, we have some of the similar problems that you have here in terms of the pressures on our healthcare systems. There's increasing burden of disease within the UK population, more elderly population, and to be honest, decreased spending in the health infrastructure as well. So a lot of the focus of care has been about ambulatory care of our patients, trying to minimize length of stay of our patients whilst providing them with expert care. And that's partly what I'm going to talk about going forwards. In terms of the main thrust of the topic, I'm going to be talking about spontaneous pneumothorax, the pneumothorax that occurs without a traumatic incident. So I am going to talk a little bit about traumatic pneumothoraces. In terms of, this is some data from the UK about the incidence of pneumothorax. And what you can see here is that there are two spikes. The first spike corresponds with primary spontaneous pneumothorax, the second spike with secondary spontaneous pneumothorax. Primary spontaneous pneumothorax, as I'm sure you're all aware of, happens in younger patients without any apparent lung disease. Typically, these patients are smokers, and it's got a very strong link with smoking. The second spike is with patients with underlying lung disease. So typically patients in the 50s and 60s. In the UK, the predominant lung disease and internationally is COPD that causes this. So to talk about primary spontaneous pneumothorax, because that's where most of the new evidence is, what I'd like to do is present a case. This is a very routine case in the UK. So a 23-year-old gentleman presents to the emergency department after feeling short of breath for 2 days. So no underlying lung disease. So we think this patient's got a primary spontaneous pneumothorax. What you can see here is his stats he's got reasonable saturations. His respiratory rates up a little bit, but not too much. There's no signs of hemodynamic compromise. His heart rate's 82 and his blood pressure is maintained. However, he's got a large right-sided pneumothorax, as you can see from that X-ray here. And the question is, the question is whether we can manage this patient in a way other than inserting a chest drain, and whether there are other options. And so what I want to talk to you about today is about the option of conservative management, so an observational approach for this patient. I'm going to talk a little bit about ambulatory care, so using an ambulatory device for this patient. We'll talk about needle aspiration, so short-term drainage. And then finally, if I've got time and Mudda doesn't ring the bell on me, we'll talk about persistent air leak. So the question is that patient, that young patient who's not hemodynamically or respiratory compromised, can we treat that patient, even though they've got a large pneumothorax, can we treat that patient conservatively? And that question was asked in this paper that was published as an Australian paper. So it was conducted in Australia and New Zealand. It was published in the New England Journal in 2020. And what this paper did is it looked at patients with a moderate to large primary spontaneous pneumothorax. They used something called the Collins method, but it equated to the moderate to large pneumothorax. And it asked whether these patients can be non-intervened on, so a conservative approach. So it intervened it randomized 316 patients. Half of those patients were randomized to an interventional approach. So an interventional approach in this is they inserted a 12 French, so a small bore chest drain into that patient, and then see whether the lung re-expanded. If the lung didn't re-expand, then that patient was admitted. The other half of the patients were randomized to conservative management. So in this group, they would observe the patient for 4 hours within the emergency department. If that patient did not develop any signs of physiological distress, i.e. the oxygen saturations didn't go down and the heart rate didn't go up, and importantly, they could comfortably mobilize around the emergency department, so they got them to walk around the emergency department, then that patient could be discharged with early follow-up. The primary outcome, so what they were mainly looking about in this study was radiological resolution at 8 weeks' time. So whether the X-ray got better at 8 weeks' time. And what they found is that in both groups, so the interventional group and the conservative care group, almost all patients, their X-ray looked better at 8 weeks' time. So the pneumothorax resolved no matter what you did, whether you treated them conservatively or whether you put a chest drain in. They looked at a lot of other important secondary outcomes. So one of the important secondary outcomes is, does intervening, just put a chest drain, improve the symptom resolution? Does it improve the symptoms quicker? It didn't. So in both groups, the symptom resolution was 2 weeks' time, whether you put a chest drain in or whether you manage them conservatively. They looked at recurrence. This is an interesting thing. So whether that we know that that about 20% of pneumothoraces will recur with time. They looked at whether a conservative approach decreased that risk. And what they found in this study was that conservative approach halved the risk of reoccurrence. So a 9% risk compared to a 17% risk. The reason they thought this was the case is that by allowing the lung to reinflate by itself slowly, as opposed to bringing it up quickly with a chest drain, you allow that pleural defect to heal better and therefore, theoretically, decrease the risk of overall reoccurrence. I don't think this is definitive, but it's definitely supportive of that hypothesis. And this is one of the interesting findings, length of stay. So length of stay for patients admitted with chest drain was 6 days. If you treated them conservatively, the average length of stay was 1.6 days. So treating patients conservatively led to shorter length of stays. This is probably one of the most important outcomes, though. Is it safe to manage patients conservatively? And I think that's what we're all concerned about. Is this a safe approach? And so the patients that were managed conservatively, only 15% of those patients required an intervention. So only 15% of them needed a chest drain. And these 15% were in that 4-hour period. So abnormal physiological observations or intolerable symptoms were the main reasons. So the summary for that is it doesn't work for every patient. And so you still need to observe them, but it works for most patients. However, saying that, there are reasons to be cautious. This is a big study. It's the biggest study in primary spontaneous pneumothorax, but it's just one study. When we're looking at studies, we look at something called generalizability. Is that patient population that they studied in Australia, is that the same patients we see in the NHS? Is it the same patients you see here in Iraq? And we need to make that decision. They screened over 3,000 patients to recruit 300 patients. So that's 90% of patients they screened out. And we didn't get a lot of information about those patients that screened out. And so what we need to determine is, are they exactly the same as the patient cohort that we're looking at? And one of the reasons to be a little bit concerned about the findings of this paper is that the symptom scores of the patients were quite low. So on average, the breathlessness scores were 1 out of 10, and the pain scores were 2 out of 10. So that's the patient cohort they ended up with, had quite low symptoms. And that may be because they were screening out some of the higher symptom scored patients. Maybe if someone turned up very, very breathless, they thought, you're not eligible for this study. So we just need to be a little bit cautious. But I think overall, the findings are encouraging. Because of this, the BTS guidelines last year and also the ERS guidelines this year made a recommendation that conservative management can be considered for the treatment of minimally symptomatic or asymptomatic primary spontaneous pneumothorax in adults, regardless of the size of the pneumothorax. And that's the important thing, is the regardless of size. It doesn't really matter how big the pneumothorax is on the X-ray. What is important is the amount of symptoms. If they're very symptomatic, then I think we'd still be advocating for an interventional approach. But if they're not, you can consider an observational approach. Now, I added this slide in yesterday because Mudder and us, we were talking about tension or radiological tension. So there's two definitions of tension pneumothorax. So tension pneumothorax is essentially when we mean if someone's very unwell with their pneumothorax. And what we're really talking about is clinical tension pneumothorax when they've got hemodynamic compromise. As Professor Najib was talking about, that's when the intrapleural pressure shoots up and causes cardiovascular compromise. So that's clinical tension. There is this idea of radiological tension when you get an X-ray and there's mediastinal shift. And that's often reported by the radiologist that there is tension pneumothorax. Now, does radiological tension equal clinical tension? And the answer in studies and in my clinical practice is not really. So this was a study, this was conducted in Saudi Arabia, 151 patients. They looked at with primary spontaneous pneumothorax. There was reported signs of clinical or radiological tension in 8.6 patients. None of these patients had signs of hemodynamic compromise. One of them was hypoxic, but I wouldn't equate that to clinical tension. I would say that they're hypoxic. That doesn't mean they don't need an intervention, but that's something slightly different than causing cardiovascular collapse. And in that radiological tension group, the mean pulse rate was 90 and the mean blood pressure was 127/80. And none of these patients required needle decompression. My take home from that is that you shouldn't necessarily equate radiological tension with clinical tension. In my practice, what I do, if I see a case like this that's reported as radiological tension, or I see mediastinal shift, what that means to me is I'm extra careful, and I would look at that patient a bit more carefully, but I wouldn't equate that with clinical tension. What I also want to talk about quickly is that this is what I'm talking about. Spontaneous pneumothorax. Some of these findings may be transferable to traumatic pneumothorax. So in the UK, the most common cause of traumatic pneumothorax is blunt force trauma. So road traffic accidents are the commonest cause in the UK. And after that, it's having a fall. There are cases of penetrating traumatic pneumothorax in the UK. That's usually related to stabbing incidents. What I did this study several years ago. I wanted to look about whether there was a role for conservative management in traumatic pneumothorax. And what I did is I looked at our center, which was a major trauma center, and looked at we've got a very good database of patients who admitted to trauma. And what I saw is that we had 602 patients admitted for trauma during that time. 46% of those patients, the clinicians chose to manage that pneumothorax conservatively. So they looked at those patients and said, we're going to manage that conservatively. And just to look at the patients who were managed conservatively, not conservatively, the ones who were managed conservatively had smaller pneumothorax and were more well. So there were reasons that those clinicians chose to manage them conservatively. But the interesting thing about those is the ones that were managed conservatively, 90% of those did not require a thoracic intervention. So they were managed safely with a conservative manner. And the important thing is that included the patients with positive pressure ventilation. So patients who were intubated and put on positive pressure ventilation. Because there's always this idea, if we're intubating a patient, putting them on positive pressure, that will make the pneumothorax worse, and it's not safe to manage them conservatively. But 90% of these patients with a traumatic pneumothorax who were put ventilator did not require a re-intervention. Now, this is observational data, non-comparative data, and therefore we can't make any firm conclusions. But the reason I bring this up is in the UK at the moment, we're conducting a randomized control trial on traumatic pneumothorax. It's recruited over 270 patients at the moment. We're going to finish in January this year with a target of 400 patients. And that's going to be the first randomized control trial of traumatic pneumothorax for conservative versus interventional care. So I'll just keep an eye out for that because I think that could be quite practice changing. Needle aspiration versus chest drain. We do needle aspiration quite a lot in the UK. That's simple aspiration versus chest drain. I won't go this in much detail because this isn't new data, but using a little cannula, trying to re-inflate the lung, it leads to shorter length of stays than putting a chest drain in, but you need more interventions. So this is a diagram from Thelatow. 64 patients they treated with needle aspiration. Half of them were successful. They re-aspirated another half were successful. And if they weren't successful, they needed a chest drain. The take-home message for that is needle aspiration is a very non-invasive way of trying to inflate a lung, but it doesn't work all the time and probably only works about 50% of the time. And if it doesn't work, those patients will need a chest drain. I feel like I'm talking quite a long time. How long have I got? You let me know. You're going to ring the bell. Ambulatory care. This is another new technique that we're starting to use more in the UK. Ambulatory management involves using something called a flutter valve that allows air out, but doesn't allow air back in. There are different versions of this. So this is the oldest version. This is the Heimlich valve. It's just a one-way valve system attached to a chest drain, first used in the Vietnam War. This is a slightly more fancier version. There are different versions of this, but this is the atrium pneumostat. It's got a flutter valve that you attach into a chest drain. It's also got a reservoir in it that attaches secretions. And then finally, there's the sort of the most fanciest version of this, which is a pleural vent. This is made by a company called Rocket, but other companies make it. That's got an inbuilt device into it. So this is the Heimlich valve, one-way flutter valve. This is the atrium pneumostat. It got a one-way flutter valve with a reservoir. And this is the pleural vent. The advantage of this is that you don't need to stick a chest drain in first. This is a purpose-built one-way valve system that you can insert. It's got an 8 French catheter that you have insert over a needle. You withdraw the needle. You then stick the device onto the patient's chest wall. It allows air out. It doesn't allow air back in. It's also got a secretion chamber at the bottom that you can use. So that is a good device. It's quite an expensive way of managing a pneumothorax, but it does mean that patients can go home earlier. And this was shown in a randomized control trial. This is the RAMP study that was done in the UK. And what it did is it randomized patients between primary spontaneous pneumothorax. It randomized them between the pleural vent and a standard care of aspiration versus chest drain. It recruited 230 patients, and it looked at a hospital length of stay. And in the UK, what it showed is that if you manage patients with an ambulatory approach, and in this case using the pleural vent, you had a lot shorter length of stay. So 0 days with the ambulatory treatment compared to 4 days with the standard of care. However, this is a new treatment, and also you're managing patients as an outpatient. They were more prone to complications. And so if you look at adverse events, the reported complication rates in each arm, it was higher, 55% compared to standard care arm. And you always worry about that in patients that you're managing as outpatients. None of those complications were particularly serious, but it is something that we need to think about. And so when we're managing patients as an ambulatory care, and it's the same when we're managing with conservative care, what I would call these as pathways as opposed to individual treatments. Because if you are managing patients and with either conservative care or ambulatory care, you need to make sure that the patient has a robust follow-up system, that they know how to get in contact with you, that you have some form of outpatient follow-up with them. This is the flow diagram from the new BTS guidelines that was published last year, and it probably doesn't project too well, but the first question you've got to ask yourself with our new guidelines is the patient symptomatic? So very patient focused. The next question is the high risk characteristics. If the patient got any high characteristics that they need a chest drain inserted. So that's signs of tension. So if they got signs of cardiovascular compromise, are they hypoxic? It also includes whether they've got underlying lung disease, secondary spontaneous pneumothorax, that you need a chest drain. If they haven't got any of those, it leaves you've got more choice. You've got choice as a clinician, your patient's got choice as a patient. And so you can either think about conservative care, perfect, ambulatory device, needle aspiration, or chest drain. Now, this is our guideline. Like with all guidelines, these are just suggestions. And in the UK, there's been various take-up with it. Conservative care is becoming more popular in the UK because we're gaining with experience with it. Ambulatory devices, it definitely works. It does involve new training pathways and teaching people how to use new devices. And so I don't think the take-up has been quite as good as I thought it might be. But I've got 5 minutes left, so I'll very briefly talk about persistent air leak, because it's, I think, a challenging dilemma. When I talk about persistent air leak, what I'm talking about is that patient that you've admitted onto your ward, that they've got a bubbling chest drain, maybe bubbling at 5 days, 6 days, 7 days, 10 days. You don't know what to do with them. The patients that this is particularly problematic is secondary spontaneous pneumothorax. You've got very severe underlying lung disease, perhaps severe emphysema, that your surgical colleagues are a bit cautious about doing an operation on them because of the poor lung function. Are there any medical things that we can do to help decrease their incidence of air leak or shorten that air leak? So this is a classic case, 67-year-old, very severe COPD, complications from the COPD, pulmonary hypertension, respiratory failure. They've got the chest drain in, they're still leaking. The options really are something called autologous blood patch, suction, or endobronchial valves. And these are the ones that were looked at in the guidelines. And I'll briefly touch upon each of these. Thoracic suction involves attaching these patients to negative pressure. In the UK, that's often done via a wall suction, though there are different types of suction. There are two contrasting arguments about whether suction is good or bad. The idea is that if you bring the lung up quickly, you get the visceral and parietal pleural together, you can heal that pleural defect. There is a risk, though, that by drawing too much air through the pleural fistula, you're actually making things worse and actually exacerbating air leak. And there's two basically camps in the UK about whether it's good or bad. And the problem is that we've got no good evidence. So the only randomized study looking at suction was in 1982. It was underpowered. It was only 40 patients. They wanted to recruit over 100. It was a mixture of patients. And what they found is they could not detect any difference between duration of hospital length of stay and success when you're looking at suction versus non-suction. That doesn't mean that it doesn't work, but it doesn't mean they could detect that it doesn't work. In the UK, we are conducting a new study on suction versus non-suction, so hopefully we'll get some answers, but I can't tell you at the moment what to do. There is something called autologous blood patch. I don't know whether it's used routinely here, but that involves instilling the patient's own blood down the chest drain. The idea is to form a clot over the pleural defect and therefore try and stop the air leak. This has got reasonable evidence. There's been 3 randomized control trials looking at autologous blood patch, 2 by chest drain, 1 done endobronchially. And what it showed is that by doing this technique, you can decrease the length of stay and decrease the air leak by a median of 5 days. So quite a dramatic effect. So essentially, I haven't got a video, but essentially it involves taking the patient's own blood. We take 1 milligram per kilogram, and then we flush that blood down the chest drain to form a clot over the visceral defect. There is one sort of more high-tech version that isn't done routinely, but has got some evidence, is using something called endobronchial valves. Now, we use endobronchial valves in the UK for as an alternative for lung volume reduction, but they can be used in air leak. So essentially what the valves do is that they stop the air going out to the fistula, to the pleural defect, and therefore can decrease duration of air leak. There isn't great evidence, so only non-comparative studies, no good randomized studies for this. The non-comparative studies are encouraging. They do seem to decrease the duration of air leak, but with non-comparative studies, we can't make any firm conclusions. The only randomized study looking at this was a Chinese study, which was a 3-way study where they used something called a bronchial occlusion spigot, which is essentially a bit of silicone which they put down the bronchial tree endobronchially. They randomized patients to just having a chest drain, to using autologous blood patch. They used that endobronchially, or this bronchial occlusion spigot. And what it found is that using this spigot decreased the duration of air leak from 8 days in the standard care to 5 days. So it had some effect, but not a dramatic effect. But it may be an encouraging way of managing air leak in the future, endobronchial therapies. So the BTS guidelines didn't make a recommendation on this, but they made something called a good practice point. And a good practice point basically means we didn't have enough good evidence, but we can make this as a suggestion. And what that said is that if patients are not fit for surgery, they've got persistent air leak, you can consider autologous blood pleurodesis or endobronchial therapies to help with the management of persistent air leak. I'll move on because I'm running out of time. But I hope that's a good summary for you in terms of the management of the acute pneumothorax and persistent air leak. And I'm very happy to take questions at the end or a break or at lunchtime or when we're having sort of the other sessions. Thank you.